All right, so here we're back with the rest of chapter 38. So this is cirrhosis. Cirrhosis is an irreversible end stage, right, of many hepatic injuries. You know, you've probably heard of cirrhosis that has to do with alcoholism. But that's not the only type of cirrhosis. Cirrhosis can actually happen due to many different causes, right? So metal storage diseases like too much iron can lead to cirrhosis. Severe acute hepatitis, chronic hepatitis, toxic hepatitis. I mean, even too much Tylenol can lead to cirrhosis of the liver. All right, so the liver is fibrotic, scarred, and nodular. If you look it up online and look for a picture of a liver with cirrhosis on it, it's actually pretty ugly looking, which normally the liver is very smooth and kind of gushy in consistency, so it'll be very nodular and bumpy. Results in permanent alteration in the hepatic blood flow and obviously in liver function, right? So biliary cirrhosis. The etiology of this is the end result of continuous ongoing inflammation of the bile ducts, right? So some sort of biliary obstruction resulting in the backup of bile into the liver. So we're talking about like if you have a stone in your common bile duct, for example, that would be stuck there. That's going to be pretty serious for it to lead to biliary cirrhosis, but it can. Microscopic and large duct obstruction. Pathogenesis is going to result obviously in inflammation and scarring of the liver with the bile ductules being affected and fibrosis and nodule formation and portal hypertension, which we talked about in detail. Right, so some of the diagnostic criteria to diagnose this biliary cirrhosis is a liver biopsy and some appropriate serological results, such as, the treatment of your results would be, you know, altered liver enzymes and things of that nature, and especially if you're looking at hemochromatosis, for example, or something like that, then you would look at iron, you know, being too much iron, but this is biliary, so you might look at bile and other things of that nature, right, like unconjugated bile because it's in the blood, right? So treatment, right, ursodeoxycholic acid as sold as ursodiol, methotrexate, colchicine, supplementation of fat soluble vitamins, because again, because your bile is low, you're not going to have a lot of absorption of your fat soluble vitamins, and then a liver transplant if that's at all possible, right? So it could also be from a fluke. This is actually very common in other countries, right, from eating raw fish or contaminated watercress or plants, right, usually from sheep or cattle producing areas. A stool specimen and some serological testing would help us know whether it is fluke. Remember that in parasitic infections, you're going to have an increase in eosinophils. And treatment would be any anti-parasitic agents, right? You can also have primary sclerosing cholangitis. Cholangitis is usually some type of autoimmune disorder, right, with generally seen with ulcerative colitis. Okay, so pathogenesis is you'll see this increasing episodes or recurring episodes of cholangitis with primary biliary scarring and obstruction. So the end result of this biliary scarring, which is progressive, is going to be cirrhosis of the liver, right? And you also have a higher risk of getting cholangiocarcinoma, excuse me. And so that can also be quite rare, but it does happen, right? So secondary forms related to bile duct injury during surgery, so that, you know, if there is scarring to the bile duct, there could be a backup and obstruction, right? So we already talked about ERCP or MRCP, right? It shows the typical beaded and atrophic appearance of the biliary tree, right? And a liver biopsy performed for staging of the disease, right? So medical and endoscopic treatments are palliative, basically to alleviate the primary symptoms. Of liver transplant may be possible. Right? An alcoholic fatty liver, right? So Pathogenesis is alcoholic steatohepatitis. It's fat accumulation in the liver cells. So one of the ways you might see that is definitely with a liver biopsy, right? So causes, more fat is delivered to the hepatocyte than can normally metabolize, because remember, ethanol is hydrophobic, right? And so then it can lead to defect in fat metabolism within the cell. Then usually mild and asymptomatic, you may see liver enlargement, abdominal discomfort, and portal hypertension, right? Diagnosis is hypertriglyceridemia and liver enzymes that are mildly abnormal, right? So the treatment is stopping alcohol intake, providing appropriate nutrition, and non-alcoholic steatohepatitis, right? You see a weight reduction, control of diabetes or hyperlipidemia, and treating the underlying cause. So if untreated, right, many 3 to 15% will progress to liver fibrosis and cirrhosis, right? So you might see that as well, right? So what is the pathogenesis of alcoholic hepatitis, right? So that's active inflammation of the central lobular region of the liver, right? So the liver cells show pathologic changes of hepatocytes with necrosis and neutrophilic infiltration, and also intracellular inclusions called Mallory bodies, right? So causes are alcoholics binge in larger quantities than usual. So alcoholism is obviously the major cause, and the mortality rate is about 33%, right? So illnesses can range from mild to severe, right? So severe can even be seen in as fever, acute liver failure, hepatomegaly, and encephalopathy, right? So it may be complicated by acute alcohol withdrawal and delirium tremens. Okay, so diagnosis is AST is markedly higher or more elevated than ALT. So the treatment is corticosteroids, treat the malnutrition and the vitamin deficiencies, which are usually thiamine, folate, vitamin B12, and K. So some other toxic liver disorders, right? Because of its role in storing and detoxifying a lot of potentially injurious substances, right? The liver is usually very subject to damage, right? So liver is important in, processing metals like iron, right? And so metal storage diseases are genetic diseases in which excessive minerals are absorbed and then subsequently deposited in the liver. So there's one called hereditary hemochromatosis, which has to do with iron, and then there's also Wilson's disease. So let's talk about those, right? So hemochromatosis is a common autosomal recessive disorder, found worldwide and prominent in Europeans, right? Is an activity of a mutant gene that allows an excessive and uncontrolled amount of iron absorption. It is a common mutation and is C28-2Y, right? And then you'll see iron deposits in numerous organs, especially the liver, the pancreas, and the heart, can progress to hepatocellular carcinoma, and early diagnosis and treatment is critical, right? So clinical manifestations, the liver is the first organ to show some involvement. So you might see hepatomegaly and elevated liver enzymes. Also, some manifestations include diabetes, hyperpigmentation, polyarthritis, hypogonadism, and heart failure. Diagnosis is usually family history, clinical features, like we just talked about, and a liver biopsy. So in the laboratory, you're going to find elevated plasma iron and transferrin saturation, and serum ferritin is usually dramatically elevated, and genetic analysis for that HFE gene. So treatment is, to begin treatment, if your iron is greater than 1,000 micrograms per liter, deferoxamine chelates iron and facilitates its renal excretion, so that could be part of the treatment. Repeated phlebotomy, which is usually the mainstay of people with hereditary hemochromatosis. So basically, they're donating blood, right, until their hematocrit is less than 37%. Right, and then maintenance of therapy of 1 unit every 2 to 3 months, and then liver transplant for irreversible cirrhosis. A patient has hereditary hemochromatosis. Which substance is elevated in the patient's body? A, iron, B, copper, C, N-acetyl B-benzoquinine amine, D, Ipsothorchis flux. So the answer to that obviously is A. Right? In Wilson disease, right? Also known as hepatolenticular degeneration, is a rare autosomal recessive disorder present usually in people 30 years of age or less and children, right? Excessive amounts of copper are accumulating in the liver and other organs, right? So there's an abnormal protein called ATP7B that is going to be elevated, right? So clinical manifestations include hepatomegaly, elevated liver enzymes of movement disorder, rigid dystonia, and primarily psychiatric symptoms. So the diagnosis is based on the clinical signs and symptoms. There is a slit lamp examination. So one of the key things is they have these brownish Kayser-Fleischer rings at the margins of the cornea. So right near the iris, at the margins of the cornea, you have like kind of a brownish kind of copper colored ring, right? So a genetic analysis is going to be utilized, right, to help the diagnosis of Wilson's disease, and laboratory findings, including a low serum ceruloplasmin and elevated 24-hour urinary copper excretion, would be highly suggestive of Wilson's disease. Right, so lifelong, right, they eliminating copper foods, right, so organ meats, shellfish, nuts, chocolate, and mushrooms. Also testing the home, because it could be copper piping at home, and filtering if necessary. Oral chelation therapy like trientine, right, which has fewer side effects, or penicillamine and zinc, and then neurologic therapy, immunotetrathiomolidate, also for the Wilson's disease. Right, acetaminophen poisoning, right, so can also cause acute hepatic failure. If you have acetaminophen greater than 100 milligrams per kilogram, exposes the liver to high levels of toxic metabolite and acetylbenzoquinine, right, so NAPQI. Normally is rapidly detoxified by liver enzymes, which is glutathione transferase, but in an overdose, detoxification reactions may be overwhelmed, and liver necrosis can result, right? So you can see here, the glucuronal transferases and sulfosyltransferases can take the acetaminophen and turn it into stable metabolites, but you have your other collection of enzymes that can convert to MPQI, right? Glutathione transferase can also make it into a stable transferase, right? But if the MPI is excessive, right, it's going to undergo, right, there's a covalent binding and oxidative stress that causes hepatic damage, hepatocyte damage, right? So clinical manifestations, so patients surviving 1 week generally experience complete recovery, right? And then nausea, vomiting, diarrhea, abnormal liver enzyme levels. If untreated, right, progressive liver failure with jaundice, you might see encephalopathy, hypoglycemia, coagulopathy, and death. Right, so treatment is detoxification with induced emesis or lavage and activated charcoal to bind things out, right? Acetylcysteine, right, also stimulates the liver to produce that glutathione to help metabolize the toxin, right? So it prevents a little bit of that hepatic necrosis and fatal consequences. Right, other structural liver conditions include liver abscess, right? So it's usually from an ascending biliary infection, right? And then abnormal infections are transported by the portal vein, and a direct extension of infections from neighboring structures are usually the sources. Most common organisms are going to be enteric aerobic bacteria and anaerobic gram-negative bacteria. Some clinical manifestations, like many abscesses, you'll see fever, right upper abdominal pain, nausea, vomiting, hepatosplenomegaly, a palpable mass, and pyogenic infection that is going to be pussy, right? So pussy-like, right, where there's leukocytosis and elevated erythrocyte sedimentation rate and elevated liver enzymes. Right, so diagnosis is usually an ultrasound or CT with or without a thin needle aspiration, gram staining of the cultures and blood cultures. And treatment is basically antibiotic therapy, right? And then maybe an CT ultrasound guided percutaneous drainage tube to remove until the abscess is drained. And that usually is going to limit morbidity and discomfort. Trauma can also cause some structural damages to the liver, like a penetrating abdominal trauma, like gunshot or stab wounds, or from rib fractures, right? So injury by blunt abdominal trauma as well, right? And then at pathogenesis, since it is a highly vascular organ receiving about 29% of our cardiac output, massive blood loss with trauma can be very, very detrimental to the liver, right? So hemorrhagic shock, right upper quadrant pain with guarding and or referred to the shoulder, abnormal rigidity, tenderness, and distension of the abdomen, right? Administration of whole blood, packed red blood cells or fresh flows in plasma, in fluid infusion, and maybe even in the ICU are some treatments for liver trauma. Liver malignancy. Liver is a very common site for metastasis of other primary cancers. So esophagus cancer, stomach cancer, colon, rectum, breast, and lung cancer, right? So it's because of the vascularity and lymphatic drainage, right? So primary liver tumors are very rare in the United States, but they are, again, a consequence of metastasis, right? So hepatocellular carcinoma is the most common form of primary hepatic malignancy, sometimes referred to as a hepatoma, right, or HCC. Common in the middle age, men are going to be more affected than women, and an increase in the United States that's related to the increased prevalence of of hepatitis B and hepatitis C viruses. Right, so some manifestations are hepatomegaly, abdominal pain, nausea, weight loss, jaundice, ascites, and paraneoplastic syndromes, including hypercalcemia, erythrocytosis, hypoglycemia, thyrotoxicosis, hypertrophic osteoarthropathy, which is your finger clubbing. So paraneoplastic usually has to do with things related to some type of cancer, but not maybe directly a cancer. So sometimes doctors will find this sequence of disorders, hypoglycemia, hypercalcemia, erythrocytosis, and then they are going to find that they fit under a paraneoplastic syndrome and then start looking for the cancer. All right, so diagnosis, alkaline phosphatase is elevated. Alpha-fetoprotein is often dramatically elevated. Ultrasonography and CT or magnetic resonance imaging or a needle biopsy are usually diagnostic, right, for the hepatocellular carcinoma. Right, and then a hepatic resection or partial resection of that area, and then complete hepectomy followed by a liver transplantation might be necessary. Right, so other treatments are chemotherapy and palliative treatments like artery ligations or direct percutaneous injection of alcohol into the tumor, cryotherapy, or other thermal techniques. Sorafenib is a new drug for hepatoma, but not amenable to curative surgery. It's not the same as the curative surgery. All right, so transplantation. End-stage liver disease not responding to conventional medical surgical intervention includes adults and children, orthotopic, so in-place transplantation, and is rarely performed for malignant neoplasms, since that usually, again, are as a consequence of another type of cancer. Right, so evaluation for the transplant patient. Right, they undergo extensive physiological and psychological evaluations. If there are no contradictions, the patient is identified as a candidate. Surgery after the donor organ is procured requires about 8 to 22 hours to complete. It's a very long and tedious transplant. Immunosuppressive prevents rejection. So most patients will be on immunosuppressive drugs like cyclosporine, prednisone, tacrolimus, instead of cyclosporine for maintenance. And side effects is obviously immune suppression. And so that causes an increased risk of infection. Appropriate vaccination. So you'll also see the annual influenza vaccine and avoiding live virus vaccinations. So most often the rejection response will happen in days 4 to 10. So if they do pass that, then they should be okay. Right, so some clinical manifestations of organ rejection include a tachycardia, fever, right upper quadrant or flank pain, diminished bowel flow or change of color through T-tube, the increasing jaundice and elevated serum bilirubin, transaminase, alkaline phosphatase levels, and increase prothrombin time. Right, so they're not clotting very well. So treatment of acute rejection is high-dose corticosteroids. Right, if no response to the corticosteroids, you might try marumonab or mycophenolate mofetil, interleukin-2 receptor blocker, basiliximab. Okay, so any of these NABs are, the MABs are monoclonal antibodies. The NABs, I'm not sure what they are, so I will look that one up for you. So marumonab is a monoclonal antibody. It's one of the first ones actually clinically available to prevent rejection. So that one is monoclonal antibody that was made in mice, so murine. And so it does not, it was actually created before the naming scheme for MABs was generated, and basiliximab works basically the same way. They block the CD3 receptor that makes basically the T cell response. So they are gonna basically stop the T cell response, right? So very good for stopping rejection. So chronic rejection, right? Progressive ductopenia and recurrence of primary pre-transplantation liver disease. So causing graft failure with time, right? So other liver diseases in pediatrics, right? So abnormal bilirubin metabolism in the neonatal period, right? So many babies are born with jaundice. So you know, what could be the reason why they are born with jaundice, right? So it's usually, if it does not last, if it lasts no longer than 2 weeks, it's harmless. So some of the causes include immature bilirubin conjugation and transport mechanisms, and increase in gut absorption of bilirubin. In breastfed children more than bottle-fed babies, beta glucuronidase in the breast milk results in increased unconjugated bilirubin in the gut. Right? So kernicterus is a brain injury related to hyperbilirubinemia that is found in babies that can be due to an immature blood-brain barrier, right? Following free unconjugated lipid soluble bilirubin entering the brain, and can lead to encephalopathy, right? So what you'll see is yellowish staining, permanently damaging brain tissue, associated usually with premature birth, neonatal jaundice, and hemolytic disease. Many infants die of this condition, right? So premature cell death from apoptosis, and so survivors can suffer from cerebral palsy, movement disorders, and mental retardation. So drugs that displace bilirubin from albumin seriously worsen the condition, right? And then exchange transfusions, phenobarbital, phototherapy, unconjugated bilirubin changes into water soluble and is excreted into the kidneys. So those treatments are pretty good for all types of bilirubinemia, actually. So phototherapy is good for all types, right? A nurse is asked about kernicterus. How should a nurse reply? Kernicterus in the neonate is A, causes brain injury and encephalopathy. B, is due to excessive conjugated bilirubin. C, creates a hepatoportoenteric connection. D, contributes to arterial hepatic dysplasia. Right, so let's think about it for a little bit, right? So kernicterus, we just mentioned, right, it's definitely has nothing to do with the liver because it's to do with the brain, right? So that kind of eliminates C and D. right? And then causes brain injury and encephalopathy. That's a very good answer. And then is due to excessive conjugated bilirubin. I'm like, but it's due to unconjugated bilirubin passing the blood-brain barrier, not conjugated bilirubin. So the answer is A. Right. Infectious and acquired hepatitis in children. Right. So acute hep A infection, it could be mild or asymptomatic, correlates with quality of sanitation and hygiene. Treatment is supportive, and prevention definitely involves careful hand washing, segregation, cleaning of laundry and personal items, and vaccination. Hep B infection is a common childhood disease and usually a vertically transmitted from a positive mother to her infant. So vertical transmission means the mother passes it to her child, right? And then give infant immunizations within 12 hours of birth. Infected blood products and drugs in less developed areas, and chronic infection is higher after neonatal or childhood infections. And so hepatitis C virus, right, less commonly spread vertically. So effective screening of blood products has greatly reduced the risk of infection. So hepatitis delta virus, right, is spread right only intrafamily route as a co-infector with hep B. So remember, you have to have hep B to get hep D. And then hepatitis E infection is common in adolescents and young adults. And so most common cause of childhood hepatitis, and then indirect cause of infant mortality. Right, so clinical hepatitis could be the causes of many different viruses, right, and the finding of an enlarged liver and elevated transaminases, and then you can assess for a congenital infection. So it's also part of that so-called torch syndrome. Right. Rye syndrome is primarily a disease of children, occurs shortly after viral illness, influenza or chickenpox, and strongly associated with aspirin use during a preceding viral illness. So it's characterized by a fatty infiltration of the liver with severe hepatic dysfunction. And some of those include encephalopathy, coagulopathy, and elevated levels of hepatocellular enzymes. So clinical manifestations are nausea and vomiting, rapidly progressing into coma. So treatment is, the mortality is quite high as about 40%. And so supportive. If the child survives, recovery is complete, and liver transplantation is reserved only for irreversible disease. Congenital liver diseases, right? So some liver diseases, babies can be born with some liver diseases, including some enzyme deficiencies that can affect multiple organ systems, such as alpha-1 antitrypsin deficiency or cystic fibrosis. Disorders of bilirubin metabolism like Crigler-Najjar syndrome, inborn errors affecting other metabolic pathways, intrahepatic ductopenic conditions, and extrahepatic ductopenia. So you might see that also called biliary atresia, which means it wasn't created, right? So alpha-1 antitrypsin deficiency, right, is an autosomal recessive condition found mainly in children and young adults. Alpha-1 antitrypsin is an enzyme inhibitor found in many tissues, right? And it normally prevents elastase and collagenase from damaging tissues. So genetically, it is a gene that has many allelic variations, but most people have the PIM allelic variation, which is a kind of the normal variation. There's also a PIS variant. And then there's the PIZ variant. And remember, you get two. You get one from your mother and you get one from your father. So that's why this one has PIZZ. If you receive both, right, of these Z variants from your mother and your father, then you will be PIZZ, which is homozygous. So they're going to produce the alpha-1 ATZ protein, which is basically deficient or defective. Right, so defective antitrypsin protein accumulates in the liver, producing diagnostic granules. So you have central lobular emphysema. It is mostly, antitrypsin deficiency is mostly what we call genetic emphysema. Pancreatic insufficiency, and you can have cirrhosis of the liver as well. So treatments right now are very few. So gene therapy is probably the only type of treatment. Some patients may receive a liver transplant or lung transplant if their lungs are worse off than their liver. All right, so cystic fibrosis is another disorder that is found mostly in the lung, but it can also have some problems in the liver, right? So it's an autosomal recessive condition that causes lung disease in children, right? So remember, it is basically the CFTR, which is the chloride channel protein, is going to be defective at chromosome 7, right? So it codes for cystic fibrosis transmembrane conductance regulator protein. That's what the CFTR stands for, right? And it basically, clinical disease requires that you have both mutations. So you have to have received both allelic forms of the defective CFTR gene, right? So complications to cystic fibrosis include pancreatic insufficiency, intestinal obstruction, gallstone disease, bile duct obstruction, right? Biliary cirrhosis, right? So usually the treatments are directed at the complications of cystic fibrosis. Gene therapy has also been done, and ursodeoxycholic acid can improve the biochemical indices that indicate liver injury. Right, and ursodeoxycholic acid also is used to decrease gallstone formation. It is actually going to break apart the meat cells that carry cholesterol, and it decrease the amount of cholesterol that's available to the liver. So it actually improves like the function of the liver. Right, so X-linked adrenal leukodystrophy is one of the many hereditary peroxisomopathies. Right, remember, peroxisomes are going to be responsible for the final steps of bile acid synthesis. Remember, peroxisomes function in the cell many times with many enzymes to help detoxify, right? So lots of peroxisomes in the liver, in hepatocytes. And then the clinical manifestations, right, include progressive neurological dysfunction and adrenal insufficiency. Treatment is ineffective, but investigational therapies have been tried. Actually, yes, Lorenzo's oil, yeah, the same one as mentioned in the movie Lorenzo's Oil, if you saw that particular movie, is a combination of oleic acid, 4 parts to 1 part erucic acid, and it's actually been experimentally tried because it lowers the amount of very long chain fatty acids which are accumulating in adrenal leukodystrophy. So it actually allows for people to live a little longer that have this X-linked ALD or adrenal leukodystrophy. I might want to watch the movie or look up a little bit more about Lorenzo's Oil. Quite interesting. It has not been approved for this purpose by the Food and Drug Administration, but it is available as a treatment for people with this disorder. It's actually a little costly, but not too costly. Some insurance companies cover it and some don't, since it is still quote-unquote experimental. All right, so zebrotendinous xanthomatosis is a disorder of bilirubin metabolism related to steroid hydroxylase deficiency. Clinical manifestations include premature atherosclerosis and encephalopathy, and the treatment is chenodeoxycholic acid, right, which shows marked improvement in the disorder. Gilbert syndrome, the pathogenesis of which is a disorder of bile acid transport, very common, 10% of the Caucasian population in the United States. It is benign, but it is an autosomal dominant condition resulting in mild unconjugated hyperbilirubinemia, right? And it's caused by a decreased bilirubin glucuronidation. Crigler-Najjar is a rare autosomal recessive disorder marked by significant unconjugated hyperbilirubinemia. Type 1 presents shortly after birth, with neonates usually dying of kernicterus or suffer irreversible neurologic damage. Total absence of bilirubin conjugation. right? So unconjugated bilirubin crosses the immature blood-brain barrier, and as we mentioned with kernicterus, it's going to lead to possibly irreversible brain damage or death. So liver transplantation after phototherapy and plasma exchange transfusion. Right, so type 2 is some conjugating capacity exists and is enhanced by the administration of phenobarbital. Can lead relatively normal lives because they do not have encephalopathy. So the treatment is phototherapy, possible liver transplantation, and gene therapy if that's possible. Right, progressive familial intrahepatic cholestasis is a rare autosomal recessive disorder with defect in bile salt excretion, with severe jaundice, pruritus, and malabsorption as their main clinical manifestations. Treatment again is ursodeoxycholic acid and biliary diversion procedures, and it's fatal unless they receive a liver transplant. You may also have inborn errors of metabolism, right? So enzyme abnormalities that result from single gene mutations, and they generally are autosomal recessive, resulting in the inability to process lipids, lipopolysaccharides, glycogen, amino acids, or proteins. Some errors are the neonatal period are fatal unless they receive immediate treatment, and errors in infancy and later years may be amenable to specific therapies. Right. So what happens in an error of metabolism is, right, the enzyme isn't working, right? So it usually results in the precursor or the reactant, right, is accumulating because you don't have a whole lot of, right, the enzyme isn't breaking it down. So you're going to have accumulation of these things. So since the liver is the main site of processing, there may be a target of the accumulation. So you might see hepatomegaly, liver enzyme elevation, and jaundice, right? So liver and bone marrow transplantation, prompt and thorough investigation of family history, genetic counseling, and testing of family members. Other intrahepatic cholestatic conditions include, right, a cholestatic liver disease in which a pathological process is confined to the liver, right? So the extrahepatic biliary system is normal. So some of the causes for this is neonatal hepatitis and conditions in which the number of bile ducts is decreased and inadequate, right? So you don't have normal bile metabolism and transport, right? Alagille syndrome is material hepatic dysplasia. So it is an autosomal dominant condition, right? So typical bony and cardiovascular malformations, and you have a decrease, right, in the intrahepatic bile ducts. Slow progressing, and the treatment is the ursodeoxycholic acid until liver transplantation is available, right? So some of our extrahepatic cholestatic conditions, again, biliary atresia, right, is also called progressive obliterative cholangiopathy, also called extrahepatic ductopenia. It could be either congenital or acquired. So it's a common birth defect affecting 1 in 10,000 to 15,000 live births. Occurring in certain autoimmune illnesses, and it's the principal form of chronic rejection of a liver transplant allograft. Right, so clinical manifestations is progressive cholestasis with all of the usual features. The cholangiogram and liver biopsy are diagnostic, and the Kasai procedure creates a hepatoportal enteric connection that allows for adequate bile drainage. Not curative, but it does allow the time to get a liver for liver transplantation. Right, so in geriatric populations, right, so the liver size and blood flow decrease with aging. So careful monitoring of medications that affect hepatic blood flow and that are processed by cytochromes, right? So hepatocellular carcinoma is more often seen in older patients, right, related to alcohol or chronic viral hepatitis, and prognosis is very poor in people in the geriatric population. Ischemic hepatitis, also associated with cardiovascular disease and episodes of hypotension, and much more common in older patients, right? There's a rapid elevation of serum transaminases and prolonged prothrombin time. Recovery may be rapid, but it depends on the severity of the underlying disorder. Hemochromatosis in women occurs after menopause, may have a new onset diabetes mellitus, heart failure, arthritis, cirrhosis, and hepatocellular carcinoma. Autoimmune liver diseases, right? Chronic active hepatitis may be a cause of cryptogenic cirrhosis in older women, and primary sclerosing cholangitis affects older persons with long-standing ulcerative colitis, and even those with colectomies performed many years earlier. Alcohol abuse, right? Cumulative injury of years of exposure to alcohol also starts to show signs of advanced disease. Intoxication and hepatic encephalopathy may be confused with senile dementia, so made worse by also drug use at the same time, right? So treatment is the same as a younger patient, obviously noting social circumstances, concurrent medical problems, etc. Acute viral hepatitis is much more difficult, related to non-specific symptoms, and is decreased clinical suspicion. So you might see acute hep A infection, much more severe, much more higher mortality rates in the elderly. And so even close monitoring with standard treatments, right? Because it is also comorbid with other conditions, and intolerance of side effects, advanced liver disease may prevent treatment from being as responsive as it is with a younger patient, right? So liver transplantation is no arbitrary age limits have been set, right? So, that's probably not the case though. All right, so your gastrointestinal function case study will be covered in class. So I'll see you guys later.